is a very tough taskmaster, and she insists that we start right on time at 8:30, so we're going to go. My name is Bob Hendra, and it's a pleasure to be here today to introduce our speaker, Marina Tolou-Shams. I was privileged to be on the recruitment committee that brought Marina here several years ago from Brown University. She's now an associate professor in residence here in the Department of Psychiatry and the director of infant, child, and adolescent psychiatry at the Zuckerberg San Francisco General Hospital. She has a strong career in mental health, forensics, helping the underserved, with women in correctional facilities, with HIV, all areas where we need so much. And it's such a pleasure to be able to have her today tell us more about it. Gina also tells me I have to keep the introduction short. So, so I said as many good things as I can say at one time, Marina.
Thank you so much. Good morning. Hi. It's so fun now, having been here a little over 3 years, to actually know many of these faces in the room. So thank you so much for coming this morning. I am going to, can you hear me okay? Yes. So I just want to make sure that you can hear me okay with I covered the microphone. I'm kind of trying this elaborate task. There we go. Now I'm sure the other sites can hear me. Thank you, Lowell. So I'm going to talk to you this morning about mental health and juvenile justice, and some research that we have just started to begin really looking at in terms of how we might think about how we use technology to improve access to mental health and substance use services for justice-involved youth. So this work cannot be done without an entire team, and this is our Bitmoji lab. And so this is our juvenile justice behavioral health team over at the Zuckerberg San Francisco General Hospital. But there are many others who we need to acknowledge in order to be able to do this work, including our funders, National Institute of Drug Abuse, National Institute of Mental Health, NCATS, and the CTSI for actually providing a RAP grant to fund some of this work, as well as the department, the Marilyn Reed Lucia Pilot Project funding that has all been contributing to this work, which is exciting. And not to mention our community of children, youth, families who participated in this research, as well as all of our partners, so juvenile probation, San Francisco juvenile courts, and the diversion programs in the community, like Huckleberry House, who we partner with on all of this work. So we have several different studies going on or just recently ended in our lab, and I'm going to focus on two today. One, several of our studies are focused on mobile health, digital health, which is going to be the bulk of what we'll talk about today. And then in order to talk about kind of how we arrived at thinking about this work and turning to technology, I'm going to present some findings from one of our large-scale assessment studies of 400 first-time offending court-involved non-incarcerated youth. And I will define all of those terms. So I'm going to start by talking a little bit about the juvenile justice landscape and reform. This talk is actually really timely because there's a lot going on in San Francisco right now related to this topic. I'm going to talk about mental health and substance use as intersecting risks for justice involvement, initial contact, and also continued involvement or reentry. I'm going to talk about barriers to treatment access and engagement that our justice-involved youth and family populations confront. And I'm going to present to you some very pilot data that's really like proof of concept data in my mind as to how technology may hold some promise for improving youth behavioral health and legal outcomes. So just an overview of the waves of juvenile justice reform, because I recognize that maybe people might not know about the waves. So a first wave of juvenile justice reform was in 1899. That was our first juvenile court established. And it was a rehabilitative approach, actually much like our fourth wave that we're currently going through right now. Children are different from adults. They're less responsible for their actions and thus not deserving of adult punishments. And there was a societal interest in protecting and investing in their futures. The second wave of juvenile justice reform came in the mid-20th century. The Supreme Court, for the first time, gave juveniles constitutional protections against self-incrimination, the right to confront witnesses, and the right to counsel. This was a really big deal, treating children as human beings. And then the third wave came around, which people are probably most familiar with. And this was when there was a response to a sharp increase in violent crime among youths in the 1980s and the early 1990s. Virtually every state passed harsh punitive laws, and many abandoned the focus on rehabilitation. Recidivism became the norm, and the brunt of harsh policies were borne by youth of color, which has continued to this day. I'm worried that, so can you hear me? I feel kind of awkward. It's almost easier for me to just hold it. Okay, that's what we're going to do. So here we are. We're still in the fourth wave of juvenile justice reform, although with what's happening lately, we may be heading into even a fifth wave, which I'll talk about. So the fourth wave, in the 1990s, the crime wave subsided. And so by the end of the century, mayors, governors, legislatures across the nation started to recognize the high fiscal and social costs of incarceration. And at the same time, we had leaders in the field, Tom Grisso, Gina Vincent, through the MacArthur Foundation, who were talking about we need to be thinking about development. We need to be thinking about developmentally informed approaches to providing care for these youth, and we need to think about how we start to integrate mental health needs and addressing those with this population. And there was also increased recognition around the value and impact of addressing trauma. These things weren't discussed before this fourth wave. And so here we are today. This is a clip from the San Francisco Chronicle, for those of you who may have seen the series that's coming out, about our rapid, or our not necessarily rapid, but consistent decline over time in youth violence rates. And consistent with that, you see all over the country that juvenile placement rates have declined in every state from 2006 to 2013, and 9 states cut their rates by half or more. You can see here, California, see right here is the green. California cut its rates between 40 to 49%. But what we see here is, despite declines, the placement rate for minority youth is still 2.7 times that of white youth in 2013. But the stats don't look any different, really, today still. Now, this might lead us to believe that we have, that there are barely any youth who are confined anymore. Well, I just want to let you know that's absolutely not the case. We still have 53,000 youth on a snapshot, kind of daily basis, who are held in facilities away from their home as a result of juvenile or criminal justice involvement. And, you know, this is part of why San Francisco now wants to be at the forefront of paving the way. So you might have seen some of this media attention lately, where San Francisco, 3 Board of Supervisors want to draft legislation to be the first urban city in the United States that no longer has a juvenile hall. And Mayor Breed has put together a panel to look at this over the next 2 years. And our UCSF Center for Community Engagement is actually involved too, and we're getting involved in talking about how we need to think about alternatives to incarceration. And this is so germane to my talk, because as we talk about moving more youth out into the community, which has been the focus of our work, looking at what are the behavioral health needs of youth in the community and how do we help them to access those needs, we're going to be needing to think about more and more innovative, empirically sound ways of promoting access to the much-needed mental health and substance use intervention for these youth. So one of the things is not addressing those needs is directly associated with an increased likelihood of recidivism or re-entry into the justice system. So, for example, we looked at predictors of detention among youth referred for a court clinic forensic evaluation. Now, this was at a mental health court clinic where we provided rapid mental health assessments of youth who were referred by a magistrate or judge because they had some concern, whether it was that the school told them that there was a concern, the caregiver did, or the youth was presenting in front of them in some way that they couldn't quite figure out what was going on. And what we found was that youth who had a co-occurring psychiatric and substance use disorder, so dual diagnosis, adding that substance use diagnosis conferred a 6 times greater likelihood of being placed in detention 12 months after we saw them. And this is consistent with other literature that not promoting access and delivering evidence-based substance use intervention for these youth is greatly related to them re-entering the system. And we also see that there are gender differences, in particular in relation to not addressing the impact of trauma. So we looked at what the impact of sexual abuse was for boys and girls in our court sample, and what we found was this tremendous crossover effect. So for girls with a history of sexual abuse, they were dramatically more likely to be detained 12 months later than for boys. So we need to address trauma in general, but there seems to be a particularly salient effect for girls who also have higher rates of sexual abuse histories than boys. So one of our more recent studies that followed 400 first-time offending court-involved non-incarcerated youth. So this refers to other terms are community supervised, youth on probation, court-involved youth. These are not child welfare involved necessarily, although about 30% have some history of child welfare involvement. But these are youth who come in to the court based on a delinquency charge, so like larceny, assault, breaking and entering, as well as what are called status offenses. And so, that's okay. Yeah, no problem. I like my little mic. Okay, thank you. Thanks, though. So status offenders were also part of this sample. In fact, they comprise about 50%. So status offenses are those that are related to a youth having an offense because it's something that is illicit related to being underage, under age 18. So truancy, curfew, those sorts of things. And we followed them for 2 years, 7 time points, every 4 months. We assessed them on primary outcomes of psychiatric symptoms, substance use, HIV, STI, risk behavior, and recidivism. And I'm not presenting the longitudinal data today because I'm hoping to come back and do that as we're just starting to analyze the longitudinal data. But I'm presenting this to you to show you what the mental health and substance use needs are of this community supervised population, because it directly informed how we started to think about how we might use technology to promote access to intervention. So, this is a snapshot of the demographic sample. It's 54% female, which is higher than you would expect, but that's because we also enrolled the status offenders, where there's a higher proportion of girls. And we see the same kind of disproportionate minority contact. This was in, I think I mentioned this, but it was in a Northeastern family court. And you all know that I was at Brown. Bob said so. So what we see here is that the rates of Black youth and Latinx youth who are in the system are approximately double what the demographics are for the urban core of that state. And 65% receiving public assistance, 40% having an IEP. So this sample looks similar to other studies of justice-involved youth in terms of their risk factors and contextual factors and demographic factors to be considering. Also note that they were on average 14 and a half years old. So this is a younger sample coming in. Okay, so 30% reported a lifetime psychiatric diagnosis at baseline, 31% psychiatric medications, and 70% of those had psychiatric medication prescription the 4 months prior to study entry, so recently. 17% had a history of psychiatric hospitalization, And 49% on the BASC, which asks about very recent symptoms, had an internalizing or externalizing score in the clinically significant range. So this is not a sample that doesn't have mental health needs. They clearly are coming in the door, their very first contact within 30 days with these behavioral health needs. When we look at suicide trauma exposure and ACEs, 78% endorsed at least one lifetime traumatic exposure. My fellows and colleague Erica Bath at UCLA were starting to look at ACEs with our data, and we found that at least there's an average of 3 adverse childhood experiences that these youth are coming into the court with at first contact. 27% endorsed lifetime suicidal ideation, and 17% endorsed lifetime suicide attempt. These are not insignificant numbers relative to our general population of adolescents who we know are also incredibly in need. Some of these numbers are double what our general adolescent population are facing. And then if we want to look at substance use, they're using. 14-and-a-half-year-old average age coming in the door, almost 50% have used marijuana, and of those, 80% used in the past 4 months. And they're using, on average, 40 times per over 4 months. So 10 days a month they're using, on average. Alcohol use is a little less, but it's still there. And when they're drinking, looks like maybe like every weekend type thing, right? So over, and then we have 13% other drug use. So in this study, we also looked at sexual activity. Bob mentioned that one of our focus is on HIV and STI risk behavior. And so we looked at sexual activity and sexual risk behaviors. And what you can see here is that co-occurring substance use and sexual risk is a large chunk of that Venn diagram. So that's where the overlap. We've got 141 kids who are overlapping there. And then when we look at how co-occurring substance use and sex risk, let me just pull this up. Okay, so if we look at how co-occurring risk looks relative to just endorsing sexual risk or substance use versus not having either one of those risks, we see this very linear pattern where on measures of affect dysregulation, delinquency, and trauma symptoms, that those in the co-occurring risk are most severely impaired. And these scales, the affect dysregulation scale goes up to 24. So this is a pretty decently high score on the affect dysregulation scale. And the delinquency, but you can see here it goes down according to the level of risk, and that co-occurring risk is something we absolutely have to be paying attention to when we're thinking about developing these interventions. So what are the opportunities for intervention? Well, this is called the sequential intercept model. It was created by Munetz and Griffin for juvenile justice researchers to think about where and how might we think about intervening. And so pre-arrest being the earliest kind of point that a youth might come into the system with law enforcement or even through emergency services. And then going post-arrest screening, pretrial diversion, service linkage. So for us here, that might be like going to Huckleberry House to CARC, which is one of our community-based diversion programs. And then if you go on to Intercept 3, you might actually get consistently more court involved and be referred to, we call them collaborative courts here in San Francisco. So we have a wellness court, we have a young adult court actually, and the idea is it's a therapeutic jurisprudence model where the whole person is considered and they are providing supports around mental health, substance use, housing, and really the whole person care with the idea that this will reduce recidivism. And the data have been mixed on that, for instance, for juvenile drug courts, and part of it has to do with lacking fidelity of evidence-based practice for these interventions that we know work. Intercept 4 is when we get to detention. And residential, that big pie chart that I was showing you, that's intercept 4. And then reentry is another community supervised youth opportunity to intervene while they are reentering with their family or their community. And school, which is not often talked about, is how do we successfully do the reentry with school. So there are lots of opportunities along the intercept because we are lacking in approaches and interventions for all intercepts. As a prevention researcher, I want to think about starting as early as possible before they get further entrenched, but we do need a lot of work on the reentry side as well. So, unfortunately, though, we know there are tons of barriers. We know there are tons of barriers even for our community-based samples who don't have justice involvement to be able to access treatment. You know, 1 of every 7, I think you're well aware of these stats, 1 of every 7 youth, 14% receive mental, 1 out of every 7 youth who need mental health treatment actually receive it. 1 out of every 10 youth who need substance use treatment actually receive it. For justice-involved youth, even when they are detained, and access is presumably less of a barrier because of the integration of mental health services into detention. Presumably, only 15% of detained youth who need services receive it, and that number drops to 8% when they reenter the community. So we have, relative to those stats that I was showing you about need, we have a tremendous gap in terms of who's getting it. And we need to figure out what the barriers are and how we can address them. So one of the things I did was we looked at our rates of referral to enrollment in our mental health and substance use intervention studies. Now, these are research, so they're not just being referred for clinical service, right? They also have to consent to the research. So just keep that in mind, that it's not perfect from the perspective of looking at community-based referrals for clinical service, but it does give us a little window into what the referral to enrollment rates look like for mental health and substance use intervention studies for this population. Project WRAP was a family-based intervention for youth and families in the juvenile drug court. We had a 26% referral to enrollment rate. Project ITP was the integrated treatment program, and we did a family-based integrated mental health and substance use intervention and HIV prevention intervention, and the referral to enrollment rate was 28%. Project Voices is our current gender-responsive substance use treatment intervention that we're doing in the community with our San Francisco partners, and we expanded the sample because the number of justice-involved girls actually in San Francisco is declining, which is good, and we expanded it to opportunity youth, so youth in girls, cisgender girls in the schools who were using substances at some point. And we consider them like opportunity girls, opportunity to make a difference in preventing further substance use and possible justice contact in the future. But these are really low. I mean, there are questions, too, about what kind of samples we're getting, right, when we see these kinds of enrollment rates. But for now, I just kind of wanted to point this out to show that we have a significant gap in terms of when we get referrals, when the community thinks there's a need, someone's referring them, and we are struggling around enrolling and engaging. We need to be thinking about this really deeply with our community and our partners about how we help promote access and engagement. 25 to 50% of them didn't enroll due to reasons of lack of interest. They wanted the intervention closer to home, unable to contact, and decided on alternative services, but we don't actually know if they linked. This area is ripe for qualitative work. There's actually not a ton of research in this area to really fully understand what's going on here with our children and families. So we said we also wanted to look at barriers to accessing mental health and substance use services in our Project EPIC sample to try to understand this. So Juliet Yonek, one of our fellows, has worked on a paper that's in press looking at factors associated with use of mental health and substance use treatment services by justice-involved youth. And I'm just showing you one little part of the paper right now, but She did a comparison looking at the youth from the EPIC sample of those who did and did not use treatment services. You remember I said about 49% of the youth endorsed symptoms on the BASC, so a psychiatric symptom reporting measure, recent symptoms. 49% endorsed symptoms sufficient to fall in the clinically significant range for internalizing and externalizing disorders. And 36% of those youth used psychiatric services in the past 4 months. So that was higher than I had anticipated based on everything else I had shown you today. But what we saw was that 21% of the caregivers encountered one or more barriers to accessing services for their adolescent, and each individual barrier was endorsed by only 10% of the sample. So we asked about a lot of barriers. That was actually one of the failings, I think, of our measure. We wanted, because this area we know so little, we wanted to make sure we had a wide scope of looking at barriers, but that led to kind of a spread that made it a little more difficult to interpret in terms of having enough numbers in each area. But essentially, I wanted to show you that the barriers encountered by these families, there were differences between those who used services and those who did not use services. So for those, the most common barrier by those who had received services were agency or program issues. I'm running out of hands here. Agency or program issues here. So those who used services felt like that was more of a barrier, in part because they confronted the agency or the program. So there's some systems issues there, for sure. And distrust of professionals. That really stood out as well. And among youths who had not received services, the biggest barriers were transportation issues and a belief that treatment was not necessary. So with the exception of treatment not being necessary, which actually requires a separate intervention in of itself, right, around using motivational interviewing techniques, for example, thinking about working with families as to why they might feel that way, how much is distrust of medical professionals playing into that, is there an interaction going on there? And I don't want to neglect the cultural and neighborhood and family contextual factors that impact all of that. I'm not presenting that today because that's not the focus of this talk, but we have data on all of that, and we are exploring the multiple concentric circles that our youth and families live in. They don't live in this little, barrier silo, that's what it's all about. So maybe I can come back and present on that next time. But for now, we're trying to get a sneak peek to try to inform how we might think about using technology to address some of these barriers. I mean, that's really the punchline here, is how might we think about turning to technology to address some of this. The barriers that were noted, the wait lists, for example, with program issues, and the transportation, for example, are easy to think about addressing with digital health. I had a really interesting meeting with one of the most amazing attorneys who is really an ardent advocate for our youth to not be in detention and seeking alternatives to incarceration, and is very well informed about trauma and mental health practice. And I talked with her. I wanted to get her take on what she thought about online interventions or digital health interventions for her youth. And she said something that I thought, as a mental health clinician, I didn't even think about this. And she said, I really think our youth would really be open to looking at technology to address their anxiety, their trauma, because one of the hardest things they tell me all the time is, I don't want to talk to one more person. I don't want to reopen everything. I don't want to. So it was really interesting. I wasn't really necessarily expecting that, and thinking about how actually some of that distance initially could have an impact on a youth being able to address some of what is going on for them from a mental health perspective. And so I bring that up in the context of the distrust of medical professionals and feeling comfortable sharing with them. You know, when these, like I ran groups for years in detention, and when the girls are there, but it was with girls, and there's just a feeling of like being forced to have to talk. And so after she said it, I resonated with her, and I started to think, okay, well, now our task is to think about how we make those digital health interventions engaging. And the way that we do that is we co-create them from the ground up with youth and families and our community partners, which is what I'm going to talk about next. So why digital health? I've been talking about it. Barriers to access and engagement. We have significant disparities in access. These youth have fewer individual, family, neighborhood resources. They're further marginalized from access to quality mental health and substance use treatment services. I mentioned about the disparities in access for justice-involved youth in particular, for those in need who actually receive it. And the perceptions and stigma are so real. These are, I say our kids, I just mean justice-involved youth in the community have multiple layers of stigma that they are coping with, and the families, and that is just one layer of that stigma, you know, whether it's gender, whether it's race, whether it's poverty, you know, whether it's justice, being tagged as being justice involved. Just one of those is enough to serve as a barrier to access treatment. And then the evidence-based practice implementation challenges at the bottom. Several studies have aimed to train frontline staff, probation, and caseworkers in evidence-based practice to engage youth and families into care, or to even deliver substance use treatment, for example, themselves. But the studies are very few, and they really point to, and if you've worked in these systems, you understand, overburdened systems, high rates of organizational burnout, and other system-level barriers like, this is not my job. This is not what I signed up for. I'm not a mental health clinician. Why am I having to do this? In the justice arena, they call it net widening. And so there's been a lot of work done in this area, but I think digital health has an opportunity to think about how we can deliver the intervention and also actually support the staff in doing what they need to do with the youth. So that's why digital health. So my colleagues and I recently published a paper providing recommendations for how psychiatrists could also, child psychiatrists in particular, this is in JCAP, could consider adapting emerging technologies to address mental health and substance use service gaps for justice-involved youth. And we provided 7 recommendations in the paper, but 2 of these I'm going to speak specifically about: developing pilot studies that assess prototype mobile health and digital health solutions for the multifaceted needs of these families that we've been talking about, and to enroll youth and families in developing whatever technology we develop. So our first study actually is about to come out in JMIR M Health, U Health. And so we're really excited. This was funded through the CTSI RAP grant. And we developed a text messaging intervention to enhance behavioral health treatment engagement among youth on probation, actually in San Francisco. We did some qualitative work and some initial user testing. So Project Text, I know, original name. I think it was actually treatment enhancement. It was supposed to stand for something, but we just ended up all calling it Project Text. I can't remember now. So our first aim was to develop the intervention, the text messaging, and to identify individual family system-level factors fundamental to the development of this tailored SMS text messaging intervention. And then our second aim was to do some end-user testing and determine the feasibility and acceptability of this tailored SMS text messaging platform for these youth. And these were all youth who were referred for mental health and substance use treatment by probation. Now, I mentioned this is a proof of concept study. So this was a very, very small sample, which is why I'm so thrilled that we were able to publish it, because this is the first study of its kind. even just exploring this topic with this population. So we had 2 phases, our focus group and interview phase. We had 8 youth on probation, 5 caregivers, and we did focus groups with 15 juvenile justice probation staff and caregivers, clinicians in the community. And then we did end-user testing for 6 months, which I'll talk about, with 7 youth and 2 caregivers who wanted to participate. So from the focus groups, we came up with 3 themes from triangulating the caregiver data, the youth data, and the system data. So one thing is that existing use of text messaging is really, really common, but not systematic at all. And so probation are doing appointment reminders, clinicians are doing appointment reminders, or general support check-in, sometimes with the caregiver, sometimes with the youth. They actually like to text while the youth's at school because they actually have access to Wi-Fi while they're there, so they can kind of catch them and text them. There's no systematic protocol around this, and we had probation staff saying to us, I don't know what I'm going to do. This youth just texted me. I don't know if this is self-incrimination. They just told me this over text. It's my personal phone. Some had professional phones. It's just all over the place. So one area that I'm not going to talk about right now, but another area for research is to look at existing practices and think about how we develop systematic protocols around ethical and protocol-driven ways to protect both the youth and the justice system professionals. Barriers to use, they also said they love texting the caregivers, because the caregivers will respond. If they call them 2 minutes later, the caregivers aren't picking up. So tons of barriers to use, though, that came up, stigma and privacy. So it was very clear the kids and the caregivers said, don't use the word mental health, and they were really worried about their caregivers seeing their phone. And probation, and even us, we were thinking, it's really hard to know who's on the other end. So you don't know if it's so-and-so's friend, partner, or they just left it at some random person's house, and now they're getting messages about their appointments. We really had to think about that for the content. And then the messaging format. So one of the focus groups is videos, 1 minute, nothing longer. You know, YouTube, YouTube, YouTube. That was like what they were saying. So for like the psychoeducation component or the motivational messaging. Ours was SMS. We did not have the MMS texting capacity, but it's something for future. They really wanted to be clear that this was not from a robot. So when we enrolled folks in the study for the end user testing, we met them face-to-face to do the consent, and we did that even though it was more laborious, and we're going to need to think about that because bringing it to scale to do consents in person, it's not really feasible. They really said, we want to know who's on the other end, and they want a coach who they know or think is a real person. Now, the reality is we did automated. So they actually didn't know, and they liked it. So it may be just that initial engagement. We all know that there are significant trust issues, right? Like we were just talking about distrust of medical professionals. So we used text messaging for 6 months. They got automated appointment reminders 3 and 1 days before and on the day of the appointment. They had pre-scripted motivational messages sent twice a week. These were some of the sample motivational messages that we built based on direct input from the youth and caregivers, and we would do parallel with youth and caregivers. This was a dyadic intervention for the 2 caregivers who participated. Otherwise, the youth got them on their own. So always remember, you're braver than you believe, stronger than you seem. And then for the caregiver, the struggle you're in today is developing the strength you need for tomorrow. Keep moving forward. And so you'll see that they really liked these motivational messages, and it gives you some sense of how the system provides very little positive reinforcement. So we assessed acceptability, usefulness via repeat online surveys at 1, 3, and 5 months over the period, because we were kind of using it to iteratively refine the intervention. And they were asked about their opinions on the reminders, the messages, the intervention. So they used it for the whole time, like 6 months. And that really mirrors kind of the average length of time in treatment, which is why we chose that period. Text messaging helped me attend my treatment appointment. It reminded me of appointments I completely forgot about. Motivational messages were supportive and relevant. So majority like this. and they like the ability to read text messages at their convenience and save the reminder on their phone. The caregivers, the two that we had, were easy to use, read messages at convenience. They thought they were helpful as appointment reminders, and they liked the message frequency, wording, and tone. And all of them, we had an item like, would you recommend it to another parent who you know, or caregiver and a friend, and they all said yes. So with this small sample, we see that it might be acceptable and feasible to remind justice-involved youth and their caregivers of appointments. But we've got a lot of future directions and challenges, including thinking about how we make it more personalized and tailored, but not resource-intensive, identifying which systems will deliver and sustain the intervention. This is a question, right? So should it be coming from the clinicians, the mental health systems? Should it be coming from the probation system itself? We need a lot of research on ethics around confidentiality and privacy. And we need, the next step is really to do an efficacy trial to actually look and see how this impacts actual treatment, attendance, and engagement. So that's actually the next step, and that's under review right now and pending. So we're hoping that we're going to be able to do that. The other thing, that came up with the caregiver piece, so as a family-based interventionist, seeing even in that small sample, like we got 7 youth and we got 2 caregivers. Like there's a significant caregiver engagement issue, and we know that from other research, and we also know that family-based interventions are the first line, like are the gold standard for these young people. So we started to think like, okay, how can we reach these caregivers? How can we engage them? And how can we use digital health to do that? And at the same time, we started to also think about how might we, like, would young adults perhaps even be more interested in this? We know young adult is a highly risky period, and that many of the youth actually who have some justice involvement land in the adult system during that, like, 18 to 24-year-old period. And then we started to talk about, okay, everybody's doing social media. Why don't we think about that? So we came up with 2 pilot studies to start to explore use of social media for reaching justice-involved populations. And the 2 populations, we did a quantitative study on justice-involved young adults' willingness to participate in behavioral health research through social media and digital health interventions. We wanted to ask the question, like, can we even recruit this population through social media? It's taken us almost 4 years to enroll 130 girls in San Francisco into our outpatient substance use treatment. So just keep that number in your head of like how many, when you see how many we were able to reach through social media, it doesn't look like a huge number relative to other social media studies, but keep in mind how long it took us in the community to recruit that number. And then study 2, we did a mixed method study on engaging caregivers of justice-involved youth through Facebook and their willingness to engage in digital health interventions to start to explore this caregiver issue. Can we access caregivers and engage them through social media? And this work, as I said, has been being led by my amazing fellows, Anna Harrison, who's now at the VA, and Joanna Folk, and all of our team, who is all here, and Amanda Wallace. So I'm thrilled to be able to present some of these initial findings. So our first study, 18 to 24-year-olds past year arrest and not incarcerated. That was our target audience. There were 506 people who attempted a survey, and of those, 197 were eligible, and 134 consented and completed the survey. I have to tell you, this is why I told you about the girls and recruiting in the community. We were jumping up and down. I was like, I've never recruited so many participants who have justice involvement this quickly. So we did it through Reddit and Facebook. So Reddit has various groups that we can, they have a probation thread. And by the way, I'm so not up on the lingo on this. I totally rely on my research team to help me with this. I'm just trying to figure out how to tweet and survive. So the Reddit was one of the platforms, and then Facebook was the other platform. And we ran, we ran the ads for 8 weeks.
And so this was an example of one of our ads, and we really struggled with, like, how do we, like, what image to use. I mean, there's just nothing out there to think about. So we had 197 young adults, and they were on average 21 and a half years, largely male, 60%, although this reflects the male to female proportion we typically would expect, 42% white, and the rest racial and ethnic minority. And then these were the different types of current justice. So they had to be arrested in the past year, but they didn't necessarily have to have active justice involvement when they completed the study. So what did they say? Well, only 35% said they would probably or definitely participate in an online program. And they said their most frequent preference, like their preference was for the appointment reminders via text messages, just like our youth and our caregivers, and having an online peer support community, which was interesting. So they had concerns that they noted. Privacy, not having a computer, financial incentives, feelings of shame, lack of accountability, fear of exploitation, interference with other programs, staff qualifications. They said I would need to see the professional licenses before I invested time. I'd rather do something. And then someone said about accountability that they'd rather do something like this rather than in person, as it's easier to put my pride and ego aside over the phone rather than in person where I'm more apt to lie. So that speaks to some of what I was talking about earlier, too, with having in-person intervention for the youth and what the attorney was speaking to as well. They thought there were lots of benefits, too: convenience, accessibility, flexibility, group support, and affordability. And there was a theme of expansion of support, like that it felt supportive to them to have something online. And here we go in terms of the barriers. I think it's a good idea, especially for those of us who work a lot, don't drive, or have a bad time management skills. I love that lesson. So this is just the beginning, we're just seeing, but we did find we could actually recruit, presuming that what's on the other end is actually accurate, that they're accurately reporting. But given the ineligible and eligibility, we did a screener. We feel quasi-confident that we reached the population. The questions are now, what next? Like, what do we think about? And they've raised a lot of concerns that I think we need to really be thinking about and potentially doing more research on. Study 2 was our caregiver of youth with past year justice involvement. Similar kind of ad. We just did this through Facebook. There were almost 400 attempted surveys, and 239 were eligible. Only 156 though consented and completed the survey. We did a lot of revisions to our surveys because we figured out really quickly they were too long. Really classic academics, you know, trying to measure everything. Nope. No. So we had to revise it. And actually, the other piece that we learned, our consent was too long. People were shutting down, like literally, like, nope, doing it. And once we revised our consent and got it through IRB again, we saw our enrollment rate go up. So our caregivers were on average 43 years old, and their youth was 15 years who had past year justice involvement. And here we see a higher proportion of caregivers from racial and ethnic minority communities. And this is nationwide. I'm sorry if I didn't clarify that, but this is nationwide. So I don't actually have the descriptives of where exactly they're from, but we have those available. And 45% were reported being in a marital status relationship. Forward. It's not forwarding. Okay. Well, so where our text board is. Okay. Oh, I'll just do that way. Okay, I got it. Thanks. So what did they say? Well, 96% owned a smartphone or a tablet. So we know there's access there. And 87% regular computer access, and 72% use Facebook regularly, which is much higher than our youth samples, right? They're like, Facebook is for old people. That's what they always say to us in our focus groups. 99% of those Facebook users are active at least once a day. this was interesting. 28% were currently participating in an online support group. And of those, almost 60% said it was specifically for caregivers of justice-involved youth. So I don't know whose intervention they're participating in. It would be great to know. Maybe it's a support group that's just being pulled together, like an online support group. Although here they felt the same way: supportive, motivational text messages and posts online, and an online support community would be great. Those were their favorites. And a private Facebook support community with caregivers and mental health providers. They really wanted this community to help them figure out how to address the mental health needs of their youth. So what we did here, which is what I wish we had done with the young adult study, is we actually asked caregivers if they'd be willing to participate in an interview. And we had 50 caregivers of those survey respondents say they would participate in an interview. And so we've completed 18 interviews, and there are 3 themes that are coming up. So one is that parenting stress tends to increase and be high once youth become justice involved. Justice involvement of one's child tends to have a negative impact on caregivers' lives across a wide variety of domains, though. They talked about work, they talked about relationships, and other responsibilities. The second is that barriers to treatment access came full force in these interviews, and little support is provided to getting connected. That was really a highlight of this work. And so they came up with the same barriers, but they also added one: the youth's willingness or motivation to go to treatment. And as a caregiver, how could they get support to enhance engagement for their youth? But scheduling, transportation all came up as well. And the last thing is they're open to digital health interventions. They are already doing, some of them, support groups through Facebook, and they want to be receiving text messaging reminders about appointments. And what they noted was the primary benefit was convenience, that they don't have to travel, that they can access at home, because clearly they have the resources to do that. They've got their tablets, their smartphones. And they did bring up, so when we started doing this was when all the stuff about Facebook, privacy, security started. So there were definitely concerns raised about that. But they said if it was a secure online platform, like through UCSF, they would be absolutely open to it. So in summary, and then we can have about 5-6 minutes per questions, juvenile justice reform and diversion efforts equal behavioral health services need in the community. Barriers to access and engagement are pervasive. We're hearing it from every single type of data collection that we implement. Digital health interventions may be a feasible and acceptable option to address youth and caregiver needs at any and all justice system intercepts. So you could start to imagine how we could think about developing different text messaging services or different support, online support groups. Or we're going to meet with Alameda County Detention this Friday. They have their assistant chief of probation has managed to get tablets inside the detention facility that have only a portal to secure platforms that they approve. So we're talking about how we might start to deliver digital health intervention to youth while they are in custody. And this is pretty groundbreaking. There are very few facilities that even allow for that. San Francisco, we can't. Provide multiple different types of needed intervention. So you could imagine like a text messaging support service for the probation staff to help them keep track, or a portal that they could log into and communicate with clinicians in the community to de-silo care and enhance communication. And then you could also have a youth individual intervention around enhancing engagement to enhancing treatment engagement for substance use, for example. And then I just mentioned the example about coordinating services, de-siloing, and then bringing evidence-based services to scale. So one of the things I talked about were the fidelity issues, right, and bringing evidence-based practice and the challenges that with overburdened systems. If our clinicians and our systems and our juvenile justice systems can see this as an adjunct, as a helpful adjunct to what they are trying to do and scrambling with to make happen, then we have an opportunity to develop these with the evidence base in mind and see and bring more fidelity of our interventions to the systems. So thank you very much for all your time and attention. Questions? Yes, Dr. Stewart. Yeah, so it's a great question. So the question was, how do you propose sustainability of these interventions and which system owns it and sustains it? And we actually don't know the answer to that yet. That's part of the research that has to be done. So any grant that we're currently putting in right now has a sustainability phase, but up front. So the idea is, one of our colleagues at UCLA has this approach called participatory informatics, and it's really using community-based participatory research principles, community-engaged research principles to co-create apps. And he's got an application that does not require tech savvy. They're literally co-creating. And so anything that we're actually putting in for funding for Next Steps is taking that type of approach, whether it's text messaging development or an app, and asking this question right up front. Too often what we do is we say, let's develop the intervention, and then we'll figure out how to sustain it. And we're really seeing that we have to ask that up front and see who wants it. So actually, the clinicians and probation were super interested in it. But it becomes a cost issue, and I think the only way you get them to buy into that is if you show cost effectiveness associated with it, which is another area that we have to approach. Great question. Yes. Hey. Uh-huh. Oh. That is such a great question. It's, a lot less. I mean, this was, but see, that's brilliant, because it was literally with $1,000 seed funding grant from the department at ZSFG for the justice-involved young adult. And, I mean, to be fair, it was fellow power, too, like trainee power. So we have to factor them into the cost. And then the caregiver study is from the department, and it's a $10,000 grant, and we can't spend it. Like, we haven't figured out how to finish spending it. So your point is absolutely well taken, and I'm going to go and calculate that, actually. Thank you for that comment. Yeah. Yeah. And are you thinking, how do you encourage that online or just in general? In general. Yeah. Right. So about the peer piece, we do have those data, and we haven't looked at them for EPIC, for example. One of the things I will tell you, and we're working on this paper right now, when we're talking about kind of more individual characteristics and then peer and school, youth who came in, their first contact, who were not using marijuana, we looked at how psychiatric symptoms, delinquency, all of the kind of known factors that might predict future substance use with an attempt to prevent it if we address mental health. We also included, we have a motives measure and an expectancies measure. So what kind of expectancies do these youth have around what marijuana use is going to do for them? Is it going to be feeling good or not feeling good? And we put all of that into the model, and the only thing that predicted the 18% of youth who initiated use for the first time over the following year was whether they thought marijuana was going to make them feel good. So to your point, just about the self-medicating potentially, but that was the most salient driver. And it speaks to, like, I started thinking about, like, can they do a brief online intervention to change expectancies around use? Could that actually be a prevention intervention for these kids? And if we delay their onset of marijuana use, we also have the potential of preventing recidivism from the substance use data I showed you. We're out of time. Thank you. Thank you.